Yeah.
So I'm going to state like the relationship between IPF and UIP, and you tell me where I'm getting it wrong, okay? Okay. So
Yeah.
let's do it like this. So for a diagnosis of idiopathic pulmonary fibrosis or IPF, for Dr. Tolle to make a diagnosis of IPF, he needs either a CT diagnosis of UIP or a pathologic diagnosis of UIP, and he needs to have come to a decision that that UIP is of unknown cause, and that's when the label of IPF is made. So you need either radiology or pathology to say it's UIP. So is that general framework correct, Les, or how would you state the relationship?
Yeah, no, that's absolutely correct. I mean, that's what I sort of tell our fellows and residents and med students and stuff. It's idiopathic UIP. So once you are convinced that that you can't find a reason for their UIP, which, you know, maybe just a provisional diagnosis, but that's when I start calling it IPF.
Yeah. Okay. So I think that's the basics. Now, if I could just jump into a slightly controversial topic, Les. I know we had a pro-con discussion on this in one of our recent, internal meetings. The question is of UIP, that is idiopathic. So the question is the difference between UIP in an idiopathic setting, which is IPF, versus UIP in any other setting. In a patient with a bird, or a patient with a CTD, or a patient with asbestos exposure, or a familial patient with a family history or a telomerase mutation. So my question to you, Les, is there a do you think there is a difference in all these various UIPs in terms of how they behave or how they respond to treatment? Why do we make such an effort to tell the etiology of these patients?
Yeah, so that is a controversial topic. I think my personal bias is once you have UIP, I think it behaves pretty similar, whether it's RA or HP, whatever. I think that what what I struggle with is what's driving the UIP, right? I think if you have a case where it's like rheumatoid arthritis, for example, and presumably it's autoimmune driven, there's some sort of, uh, autoantibody or antibody in general that's driving the injury to the lung, causing the UIP. And I think that you could make an argument would warrant treatment to prevent further worsening of scarring or new scar from being developed. I think there's likely two pathways in there. You've got the rheumatoid pathway leading to the UIP, and then you've got the UIP sort of progressing on its own.
Yeah.
You could make an argument to treat both. Similarly, in HP, where you've got your, antigen, whatever it may be, driving inflammation, which causes scar, and then the scar causes more scar. And so maybe you need to treat um, both pathways. But I think that once you've gotten UIP, I think my personal bias is that UIP creates worsening scar, whether it's just the mechanics of it or whatever it is. And I think that pathway in and of itself will behave in a progressive nature.
Do you feel that the UIP that occurs in rheumatoid arthritis or scleroderma, that group especially, is slower to progress than regular UIP, or is it roughly similar?
Yeah, I think the data is really all over the place on that. It's so inconsistent. It's really hard to know. Um, I think that once you have UIP, it's fairly aggressive. However, I think that we're there's probably a sort of a lead time bias that we didn't appreciate with IPF. That like we are diagnosing cases so much earlier than we used to.
Yeah.
That the prognosis it probably is better in the sense that we're just diagnosing it earlier and it's in the
Yes.
background.
Hmm.
And so I don't know that in general we have a really great sense of how quickly these progress, whether it's IPF or RAUIP or HPUIP or scleroderma, whatever.
Yeah. Yeah. That's very helpful to know. That's very helpful, Les, because that's really it affects us as pathologists a lot. The hunt for an etiology and
Yeah.
how we think our role is. So it's very helpful to know this.